I'd like to welcome you to the talk from the Boston Fetal Cardiac Intervention Program. I'm Louise Wilkins-Haug. I've been the maternal fetal interventionist for the program since its beginning in 2001 and would like to bring to you today where we are currently with the program. I have no disclosures. So where did we start and where are we today? I think over the span of more than 15 years, we've certainly looked at how do you evaluate a fetal intervention overall, and then specifically for that intervention, in our case, the fetal cardiac intervention, what are the outcomes and then what are the complications? And then lastly, as importantly, is what are the unanswered questions that remain? So when we started in on the fetal cardiac intervention program, we had to feel that we had a sense of what the natural history was. Not only the natural history of the neonate with hypoplastic left heart syndrome, as I'm showing here, but also the natural history of the fetus. So at the point in time when we started this program, certainly the options for the neonate with hypoplastic left heart syndrome were basically three, and in many areas of the country, these remain the three options. Compassionate care, as the infants born with hypoplastic left heart syndrome without repair, it's a life-limiting disorder very quickly in the newborn period. Certainly, then there's also the options of heart transplantation, given the complications of long-term survival even after surgery when converted to a single ventricle. And then lastly, there's been a lot of progression in the development of a three-staged Norwood procedure, which initially takes the hypoplastic left heart and realigns the vascular flows so that over a process of 3 stages, the left ventricle is isolated and the systemic circulation for the heart then becomes dependent upon the right ventricle, leaving the infant and then the child with a single ventricular heart. And as you can see here, it requires quite a bit of staged procedures in order to have both the cardiac inflow and then the outflow be dependent on one ventricle, which is the right side. Now, as we knew, as we started in the program more than 15 years ago, there had been in the late 90s, as you can see here, quite an improvement in the survival at the year after a stage 1 of the Norwood. So essentially that first of 3 stages where they're going to convert to a single ventricle heart. So as shown in this graph, the survivorship for stage 1 procedures had gone from less than 50% to well close to above 90%. So I think the question, though, arose at that point in time, while the survivorship of being able to technically convert to a single ventricle had improved greatly, there were follow-up concerns that were starting to appear around 2000. Certainly some of these infants who had been converted over to a single right-sided ventricle were experiencing sudden death. As they became older, they were undergoing congestive heart failure and a need then for transplantation. And there was also a growing recognition that these infants had a neurologic deficit which was long-lasting, and at that point in time was unclear whether it was related to the procedures themselves or just the single ventricle physiology. I think all three of these concerns arose from the understanding that conversion to a single ventricle then has the neonate child and developing individual reliant for their higher pressure systemic circulation from their right ventricle, which was never initially geared to that level of pressures. So as you can see here, we also looked to make sure that we had some history about how the fetus with hypoplastic heart syndrome develops. And in this first image here is a normal 4-chamber heart. As you can see here, this is clearly a hypoplastic left heart from early in gestation. At this 18-week scan, there's been no development of the left ventricle and usually associated with significant inflow and outflow damage to the valves, either as a primary or secondary etiology with severe stenosis or atresia. We did, however, notice that certainly in many persons' experience, as they began following some of these infants through the second trimester with a greater utility and use of second trimester ultrasound scanning, that there were infants that had what appeared to be a normal 4-stage heart on their 18-week scan, who on delivery then were noted to have hypoplastic left heart. And at times, parents came back saying our scans were normal at 18 weeks. What occurred? And it became recognized during the late 90s that for these infants who appeared to have normal 4-chamber views at 18 weeks, they indeed have a 4-chamber view that was normal, but if the aortic valve had been interrogated very closely, it could be seen that there was decreasing size and stenosis to the aortic valve, typically not atresia, but certainly a very severe aortic stenosis that was then impeding flow across the valve and increasing the left ventricle pressure. What was developed then through the late 90s and the early 2000s as we started this program were criteria that were published in several different studies, as you can see from our combined program here with Boston Children's Hospital, to really try to identify who was the infant who had hypoplastic left heart, who initially at their second trimester ultrasound had what appeared to be a normal 4-chamber. And we were very careful and focused on assuring that we selected candidates who had a potential to still retain their left ventricle despite severe aortic stenosis. But we also wanted to make sure that we were not erring on the other side, that this was a fetus who was going to have aortic stenosis but not progress on to hypoplastic left heart. And so certainly these 4 characteristics here, which really look at whether or not the physiologic flow has altered in the left ventricle, became very important as parameters to use to say that not only was there decreased flow across the aortic valve, as noted here in one of the criteria, but then also that the physiology had changed so that there was still length left to the left ventricle, but certainly there was altered flow dynamics, that there was reversal, there was retrograde flow in the aortic arch, so that there was not enough flow across the valve to keep antegrated flow present, and then there was also a change in flow across the foraminal valley so that there was now reverse flow across the foraminal valley. So these considerations were then found to be highly predictive of a severe aortic stenosis in the second trimester that was going to progress on to a hypoplastic left heart if no intervention was performed. And the proposed approach was very similar to that which is taken in the infant and newborn who has an aortic stenosis but who has continued flow and doesn't progress to hypoplastic left heart. So indeed there are some rare children who have aortic stenosis and as a neonate or a young infant are identified and then have a cath procedure performed once they're delivered. However, in the instances where the physiologic flow has already reversed, the proposed procedure was similar to what's done in the neonate. So it was to be a left ventricle approach. Certainly there's a different approach used to get the wire when it's done in the neonate. It's usually done through one of the vessels. But in the fetus, the most direct approach was through the left ventricle. There was historical knowledge that cardiac puncture could be performed at times early in prenatal diagnosis when they were looking for direct diagnosis of hemoglobinopathies. They would use a 22 gauge syringe and remove blood from the heart, and they would also transfuse blood back into the heart at that point in time with about a 10% fetal loss rate. So we felt that there was some precedent for doing a direct cardiac puncture, and we wanted to be within the left ventricle as shown here, and then aligning our trocar, which is styleted, up as close to the aortic valve as possible. The idea being that we would remove the styleted apparatus from the trocar and then a guide wire would be fitted down the trocar, which was placed at the aortic valve, and the wire floated then across the stenotic aortic valve, and then following the track up through the aorta. On top of the wire then, just as done with any dilation, is a balloon which once in place across the valve can be insufflated to become larger and actually just balloon open the stenotic valve. So here's just a look at some of the earlier setup that we had. The introducer is an 18 or 19 gauge needle that's somewhat similar to the size a 20 gauge or a 22 gauge, which is usually the needle size used for an amniocentesis. The cannula has a rounded shoulder, and then the tip is actually a diamond tip with an angle. And the balloon catheter, which is used and shown here, is actually a regular coronary artery adult balloon catheter. So probably for our procedure, as I'll go through in a bit of these next slides, most of our time is spent trying to get the fetus into the optimal position so that we can approach the left ventricle with a single entry into the heart and have the fetus positioned so that the left thorax is anterior. And we at this time will now try for up to 45 minutes to get good fetal positioning. We'll use some gentle maneuvering here, as obstetricians do typically, to do a version or flipping a baby from bottom down to head down near term. That's the same maneuvers that we will use here. And then we use a lot of positioning of the mother on the table with her being placed either left side down or right hand side down. Typically she's under a spinal analgesia, and that can be done just with rotating the OR table itself. As you can see here, once we get into an optimal setup for the fetus, we want then to give fetal analgesia, which is given with an IM injection into the fetal buttocks, which contains both fentanyl, Pavilon, so that there's no movement, and then atropine. As you can see at the top image here, as portrayed in the cartoon, the steps are with the needle to the right-hand side of the screen up here to move the needle into placement, then in the left thorax, and come up just to the tip of the left ventricle, and then in the bottom screen here, you can see the shadow of the needle once it's come through the left ventricle. Here then at this arrow, you can see as the wire then is coming across the left ventricle, and in this lower image here, the shadow then across the balloon as it's insufflated across the aortic valve, and then this is mocked up here in this cartoon. On the left-hand side is a pre-op image of the flow that was across the left ventricle, aortic valve, and as you can see, it's actually pointing here, very little flow coming across this valve, and this is then flow also in the arch, and then immediately after dilation, we will watch and see whether or not we have flow, and you can see greater flow here across the aortic arch that's been dilated open in this second image on the right-hand side. So the procedure itself is now either done under an epidural or a spinal. We put in a Foley catheter and clamp it. We found that using a full bladder actually helps somewhat with fetal positioning because it occludes somewhat of the uterine space available. Cases are usually about 90 minutes in duration. The majority of that time is spent in trying to get the fetus into a correct position. On average, we'll spend maybe 20 minutes having placed the needle within the abdominal cavity. Much of that time, though, is spent realigning, making sure we have the best trajectory, getting into the amniotic fluid, If there's been patient consent, we'll do an amniocentesis for genetic studies if those have not already been performed. Once in the amniotic fluid, though, we will again reposition, make sure that we can come above or below any arms or umbilical cord that are present, and then, as I showed, come up right up to the skin before we make the last adjustment. The average is then no more than about 5 minutes within the fetus, and 65% of the time we can come into the left ventricle and come to the valve on the first pass. The majority of women then are discharged the next day. We've occasionally had individuals go home that evening if they're doing well. So our first 100 cases out of the 160 that we've done now, the technical outcomes, meaning how likely is it that we will be able to get the fetus into position and come into the left ventricle and successfully have a balloon come across, with the technical success being judged as immediate flow then identified across the area that was dilated at the valve. So as you can see here, this in quartiles coming from our first 25 that we did, with 68% technical success, and then with our last 25 that we did coming to 100, we had an improvement in our technical success, which I'm sure reflects just our gain in knowledge and ability to maneuver and to use other assistance, such as just turning the mother from side to side to get our optimal fetal position. Earlier on, and some changes that we've made is why were we not technically successful. The majority of times it was not because we couldn't get into the left ventricle, but I think certainly we are more selective now to be sure that we don't have aortic atresia, and we do have a minimal amount of flow. As you can see here, the greatest cause as to why we could not technically open the valve, we just couldn't get across the valve, and some of those were truly atretic. In some instances, we stopped if we had a bradycardia. Among the first 100 cases, what have been the cardiac outcomes for the cases? Again, I think as you can see here, the cardiac outcomes, the likelihood that there's going to be a child with two ventricles has increased to about 50%. That still means that the other 50%, the majority do end up going on to be one ventricle or have had a demise at the time of the procedure, and the chance that there is a fetal complication leading to loss of the infant is about 10% from the procedure, either occurring at the time of the procedure or within the next 48 hours. So those fetal losses, they are weighted, that 10% is weighted somewhat to the first 25 cases, and I think over the duration of the time that we've been doing the procedure and the 100 cases, we've improved our in utero resuscitation protocols with being able to drain pericardial effusions more quickly when they occur, and then also administering cardiac resuscitation with epinephrine and bicarb directly into the cardiac structure. What about the losses that did occur then in the infants after they were delivered? Certainly the first 100 cases, those that went on to develop single ventricle heart had, as expected, around a 10% loss at the time of their first surgery, which was what was predicted at that time and still holds true. And then there was about another 10-12% who demised prior to their first surgery. Some of those, one child was actually comfort care, one child had sepsis, and one had gone on to cardiac transplantation and then demised. So certainly around the same, maybe 10 to 15% chance of not surviving, to your first stage, and then about another 10% chance, which was pretty universal across the country, of demise surrounding your first stage. with the children who had attained then a two-ventricle heart with a technically successful dilation, there were no deaths in the neonatal period among this group. So that was a significant difference for the first 100 cases that we did. I think then to also look among our first 100 cases out beyond the neonatal period, and certainly the Kaplan-Meier curves showed a significant difference as these children became older. Those who had gone on to have a hypoplastic left heart at birth, despite having the dilation done, they had a higher rate of death than as they went through childhood, often due, as was being seen, to sudden death or need for transplantation. The upper line, the dark maroon line at the top, up here then, I think as you can see, had a much better Kaplan-Meier curve, reflecting the fact that the only loss in childhood that we had among the infants who went on to maintain their left ventricle and to have a functional two-ventricle heart after having the dilation done was an accidental car death among a child at about 2 years of age. What about the actual cardiac function and need for repairs among those first 100 cases? Even if the children were felt to have biventricular function as neonates, while they had a much better survival curve, they certainly all have had cardiac procedures. Half of them have had their valve replaced, and most of them have had further dilations done. The difference being is that they've been able to maintain biventricular function and able to use that left ventricle for systemic support. So while they've had interventions done, their overall survivorship has been improved because they have not had their cardiac function converted to the right-hand side. So what are our new areas of investigation? I think that, it's still a question that needs to be pursued as to why only about 50% of those with a technically successful intervention with an open fetal aortic valve are able to go on to retain left ventricular function. And I think we really have a limited understanding of myocardial health and a limited understanding of what the initial mechanism has been. So those are certainly areas that we need to pursue to have a better grasp on who's the best candidates for these procedures, and are we selecting candidates who actually have enough myocardial health remaining to go on to be able to support their systemic circulation on the left-hand side once they become children. Then the second question is it reasonable to continue if we never get better than a half of the children with biventricular function? Now, certainly one could argue that it is because their survivorship is better, but I think a more crucial question for us was also, are we able to alter the neurologic outcomes that seem to be related to the altered blood flow in utero? So I think to address that first question initially was that individuals working in this field were seeing that certainly children with cardiac abnormalities overall have a higher rate of neurodevelopmental abnormality and developmental delay, and it was really becoming clear that this was pre-existing their operative procedures. So certainly on their neonatal neurological exams, on fetopsy and autopsy before they ever went to surgery, infants with cardiac anomalies have altered CNS development. And certainly those infants who have hypoplastic left heart were at the highest risk for these neurologic changes even before any surgeries were done. So we have looked initially at those fetuses who have biventricular function. Their MCA Dopplers really were unchanged despite improving their left function in utero, maybe reflecting that the cerebral vascular impedance was already set. Is there a need to try to do these procedures earlier than the typical 24 to 25 weeks that we usually do them? Is there a benefit to trying to intervene earlier immediately after the ultrasounds reveal that there is aortic stenosis and altered flow. Would we be better served by intervening at that point in time in order to maintain continuous, more normal circulation to the CNS development? And certainly we did see in a small group of infants who went on to have biventricular function after they had a technically successful aortic valve dilation that their CNS volume measurements initially increased, but they ended up at the same endpoint as their univentricular counterparts, showing that even though we maintained or initially were able to sustain normal circulation to the CNS as it developed, it somehow had a preset so that they ended up at the same point. So I think there are really some unanswered questions there about the initial CNS development in the infants and whether it is all totally related to what was thought to be altered flow from the hypoplastic left heart as it developed. We also looked at the overall neurologic development of a subgroup of children that were seen for follow-up, again, at the Boston Children's Hospital, and they had these general adaptive composite scores obtained. And as you can see, certainly the children with the biventricular success appeared to be no different than those with the hypoplastic left heart. So really no overall improvement, which was a little bit below what you would see for normal children, but no different than for the children who had a hypoplastic left heart. So although the sample size is small, really no alteration in their underlying neurologic development if they were able to obtain a biventricular heart. So the question still remains in the hypoplastic left heart population. Even those who converted to a biventricular heart with the intervention, they still seem to have quite significant degrees of developmental delay compared to not only children with other cardiac defects, but also children without cardiac defects. Certainly, the question remains, is the intervention too late? Are we not able to maintain antegrade flow to the developing CNS areas continuously, or is there some other underlying CNS pathology that is going with the hypoplastic left heart, but may not be tied entirely to flow itself? So certainly an open area to investigate. One of the other areas that we've tackled is looking at whether or not we can better define which of the infants have myocardial health on their left side that can be retained. So there was not much known about whether the dilation in the left heart really produced then ischemic change, or whether it was reflecting more stretch change, and whether that would be a marker for whether it was recoverable. So we know that there are certainly natriuretic peptides, the BNPs, that are used for measuring both myocardial stretch and volume in pediatric cardiac conditions. Those were available to us to be able to assess in the amniotic fluid so that we would have some marker to look at not only what was the underlying degree of damage to the heart, but also could these then also be playing a role then in actual potential repair of the cardiovascular tissue. So not only could the BNPs reflect whether there had been substantial damage, but whether they are playing a role then in ongoing damage as well. So we had and have an ongoing study where we have consented the patients for amniotic fluid obtained before the procedure is done. And as I mentioned earlier, in some instances, the patients have opted to have genetic testing done and then consented to have us store amniotic fluid. And the first part of this ongoing investigation, we've initially started looking at the natriuretic peptides, the Pro-BNP and troponin, to look at whether it is stretch or actually ischemic changes, which is resulting in the poor myocardial health. We also have ongoing studies looking at other inflammatory markers, looking at microRNAs for pathway assessments, and then looking at sequencing and trying to identify underlying cardiac genes that may have co-influence in developing the CNS, which appears to be so altered in hypoplastic left heart, even once their valves are open. We've also are working with the Fetal Cardiac Intervention Network to try to increase these sample sizes. So what we have seen so far is that certainly looking at troponin and BNP, we were able to show that the troponin, which I haven't shown the graphs here, really had no difference, suggesting that even though there was dilation, there was not ischemic damage occurring to the myocardium on the left side of the heart. But what we were able to show, as is seen here, that the infants who had the aortic stenosis that was so severe that they dilated their left ventricle, that certainly they had much higher levels of BNP, suggesting that the damage that was being done to the left ventricles was being reflected by stretch BNP markers. And what we were able to show is that the BNP marker could directly reflect whether or not there was going to be a likelihood of a biventricular success once there was a technically successful dilation. So that if the BNP, the marker that's going to be a reflective of stretch, was low, under 900 picograms per milliliter, that there was a 10-fold higher likelihood that that infant would have a biventricular success, really reflecting just the underlying thought that while there is aortic stenosis there and the flow has altered, it has not changed to the degree that there is significant damage from stress and ongoing stretch damage to the left myocardium that is not recoverable. So of those that had the lower levels and less stretch damage to the left side of the heart, 6 out of 7 of those underwent biventricular success. Those that had higher levels of BNP, their likelihood of being able to regain left ventricle function was not 0, but it was certainly much lower than the first group that I showed that had such a high success, and they then had around a 38% chance that if the valve was open, they would actually have recovery of their left ventricle. So this seemed to be kind of a cutoff region here where we could alter a bit what's said to parents as far as the likelihood that once we open the valve, we'll be able to have an infant that retains the left-hand side, and then also gives us further information to start to look at what is the underlying myocardial damage it appears to be due to stretch, and then what are the potentials then for recovering that damage. We also have investigative studies looking at what microRNAs are present as far as looking at further roles that may be helpful to provide us information with how to recover and salvage the left ventricle health once the valve is open. And then certainly lastly, our other area of investigation is in the region of candidate genes, trying to look at what we know is a very heterogeneous group of fetuses, and they're heterogeneous at the genetic level as well. There have been widespread numbers across the genome of candidate genes identified, and whether or not there's actually gene-gene and gene and environment interaction is certainly proposed. The largest family study to date on hypoplastic left heart has about an 8% recurrence rate, and among our group of 160, we showed that almost a quarter of the siblings have a cardiac abnormality. Much of it is bicuspid aortic valve. Interestingly, among our group of aortic stenosis evolving hypoplastic left heart syndrome, we have a large predominance of male fetuses. Most of them have been 46XY, although we do have some patients who are 46XY, 45 mosaics, and some 45 Turner syndrome patients. So there seems to be a predominance of males among these very select group who are aortic stenosis, evolving hypoplastic left heart. Among our group, we saw that there was an 11% chance. So there was a first degree relative with congenital heart disease. Most of these were aortic stenosis occurring either in the fathers or the siblings. So that's much higher than you would expect for aortic stenosis, which usually occurs in about 1% of the general population, and certainly represents an opportunity for whole exome sequencing to look at what are the particular regions that appear to be most altered. So certainly the take-home points for the fetal cardiac intervention talk and for our program is that at this point in time we feel that percutaneous fetal cardiac intervention under ultrasound guidance is certainly technically possible. It can be done with a percutaneous approach and really has minimal maternal risk associated with it. Overall, biventricular circulation can be achieved in about half of the children, and certainly there are opportunities for us to further refine what that 50% success rate for biventricular function is, and there are a growing number of other ultrasound and echo parameters we can use, as well as certainly what I mentioned about the BNP levels, where we can try to isolate who are the children who have closer to an 80% chance of biventricular function and who are those who are closer to the 40% chance. Certainly among those children who achieve a biventricular function, they have a much lower mortality rate, but they do have ongoing cardiac and health issues. It really is important for parents to understand that we can get to a biventricular state. It does not mean that these children are not going to have ongoing cardiac and other health and growth issues, and certainly is an ability to alter the overall mortality, but perhaps we need to do a better job at selecting who are those who are going to have less cardiac morbidity afterwards. And I think importantly is we've not been able to show that the ability to open the aortic valve and restore biventricular circulation changes what we know now to be their underlying cognitive challenges, whether it's that we're opening the valve too late, not able to maintain biventricular circulation to the CNS as it develops, or there are other associated underlying genetic changes that are going along with the genetic changes that cause a hypoplastic left heart, or the susceptibility to inflammation perhaps, that are underlying, really all remain open-ended questions. And then certainly we're aggressively pursuing assessment of the amniotic fluid that we have stored and that we consent patients for, really to optimize our patient selection as to which fetus has myocardium that is really salvageable if we open the aortic valve, and also to explore other etiologies for treatment and understand what the underlying mechanisms are and the connection to the developmental delay. So to end with this, I wanted to present this cartoon which says, to the scared patient, we have two options, either evidence-based treatment or an exciting, risky alternative, and really just stress the commitment of any program intervening in fetal cardiac intervention or any fetal procedure to really take a stand back and look not only at the procedure, but the underlying disease state and what we're able to do and the information we're able to obtain and what are the next steps for treatment. Certainly, many thanks to the large number of colleagues involved in this initiative, Wayne Turetsky, the cardiologist who has driven this from the pediatric cardiology standpoint, Carol Benson, who a radiologist who has guided almost all of the intervention procedures, and then the cardiac team as well, the fetal anesthesiologists, the cardiac surgeons afterwards, and the nurses who were involved in helping maintain this program.